Welcome back. My first guest is Dr. Francie Masters, who is a breast radiologist. Welcome.
Thank you, Dr.
Now, mammograms is something most women recognize, and you do a lot of imaging other than just mammograms. But let's talk about mammograms first. When I trained, we first started around age 35, and then some people said, well, maybe it ought to be 40, and recently somebody said, well, maybe you should start to 50. What do you think? Who needs a mammogram? When do you start, and how long do you go?
Sure. Well, you're right, Dr. Fox, that there's a huge controversy currently over when to start screening mammograms, and most major medical organizations, including the American Cancer Society and the American Board of Radiology, still recommend annual screening mammography in women beginning at the age of 40 and those that are at average risk for developing breast cancer. And so that's what I recommend to my patients.
Now, when you say average risk, if you have a family history, do you start earlier?
In general, women with a strong family history, for instance, a first-degree relative that has breast cancer, mother or sister, we generally would recommend beginning screening mammograms 10 years prior to their age at diagnosis. So, for instance, if a patient's mother developed breast cancer at age 45, we would recommend they start screening at age 35.
Okay. Now, we talked about when to start. How long do you do mammograms? Do you do them to 80s, 90s, and some people live into 100?
You know, it varies tremendously. It's a decision that each patient has to make for themselves and with their personal doctor. There is currently no recommendation for when to stop mammography. As long as a woman is healthy and active and has good quality of life, then we continue to recommend mammography with no definite endpoint. It's really a personal decision.
Right, because you're healthy and active and don't want to die of breast cancer. Exactly. It doesn't matter how old you are.
Exactly.
Okay. Now, there is a difference between a screening mammogram and a diagnostic mammogram. Tell me a little bit about that.
Sure. A screening mammogram is done in an average healthy woman just for routine health care. A patient will come in and get a standard set of images that are done on everybody, and will get the results mailed to them. It's a patient that has no current breast complaints. They're asymptomatic. They're just getting their annual exam. A diagnostic mammogram is something done specifically for women that have a breast complaint. For instance, they may be feeling a lump in their breast. And so we tailor the mammogram to each patient in that case. So they'll get the standard set of views, but they may get additional pictures. They may also get an ultrasound performed, at the same time. And those women get the results the same day. If we detect something abnormal, they may actually get a biopsy the same day.
Now, you mentioned ultrasound. That's a little different than the mammogram.
Yes.
So tell me the difference between an ultrasound.
So mammogram uses X-ray. It uses radiation to image the breast tissue. An ultrasound uses sound waves, so there's no radiation involved. And it's just a different tool we have in our toolbox to image the breast in a different way. It's something we use to help us kind of better delineate a finding on a mammogram. So if we see a mass on a mammogram, with mammography, you can't tell the difference between something that might be fluid-filled, like a cyst, or something solid, like a cancer. Ultrasound comes into play at that point and can help us to decide if something is cystic or solid, and help us see the borders or the edges of it better and decide how to manage it.
Well, we talked about mammogram and ultrasound, but there's also something new called tomosynthesis.
Yes.
And that's really new. Tell me what that is.
This is the newest development in mammography, and currently it's used in conjunction with digital mammography. So it's done at the same time. A patient getting it might not even be able to tell the difference. It just takes a few seconds longer. So just like a regular mammogram, they're placed in compression, and the X-ray tube kind of swings around above the breast in an arc, and it takes multiple low-dose images of the breast. Those images are then put together by computer software into a 3D reconstruction, and then as a radiologist we can scroll through a 3D image of the breast by 1 millimeter slices or intervals, and it just is kind of greatly improved what we can see with mammogram.
Does everybody need tomosynthesis, or is there certain populations you're using that on now?
Currently at our facility, we're doing tomosynthesis at 4 of our screening locations where we have it available, and every screening patient that comes through gets a tomosynthesis exam currently.
Now, you mentioned, we've talked about tomosynthesis, and in that you said radiation is about the same. A lot of women are used to worry about it, saying, is this the radiation too much? Am I going to get breast cancer from a mammogram? That's really not true, is it?
It's really not. Mammography is tightly controlled by the FDA. and there are standards on how much radiation is acceptable per mammogram, per exam, and even with the added use of tomosynthesis, the dose is still very minimal and very safe. And definitely the risk of radiation from a mammogram is much less than the benefit that you get if we find an early breast cancer by using it.
Now, we've talked about mammogram, we've talked about ultrasound, talked about tomosynthesis. Some women also get an MRI. That's pretty specialized type of exam?
It is. It's probably the most sensitive tool that we have currently in breast imaging. We use it in special cases. Women that are at high risk for developing breast cancer often get a screening MRI, but that's used in addition to a screening mammogram. It doesn't replace it. We just use it in addition to. And then we also use MRI as a tool to problem solve occasionally. If a woman has a complaint and we just can't get to the bottom of it with mammography or ultrasound alone, sometimes we might recommend an MRI. And occasionally in a woman that has a newly diagnosed breast cancer, we might use MRI to evaluate how extensive the cancer is and to evaluate the other breasts as well. So we use it in a few unique instances, but no, not everybody needs a breast MRI.
Now, a lot of women will say, you know, it hurts, it's cold, I don't want to do it. A lot of them really mean I'm afraid, but there's really nothing to be afraid of in terms of getting a mammogram.
There's really not. I think definitely some women mention discomfort from the compression, but we try to be as gentle as possible with compression. The reason we do compress the breast tissue is twofold. One is just it helps spread the tissue out. So often a culprit in getting called back is that tissue is overlapping and creates what looks like a mass when actually it's just tissue superimposed on other tissue. So compression helps spread the tissue out so we can see things better. And compression also helps hold the breast still, so there's no motion on the film that we're looking at. If a film's blurry because a patient moved, it's virtually useless to us. And
that's when women will be called back for another image, but really most callbacks are just fine, just need a better image.
Often that's the case, and with the use of tomosynthesis, actually the callback rate, the false positive rate should go down because we're scrolling through one image at a time. It should eliminate a lot of those artifacts caused by breast tissue that's overlapping.
Okay, great information. Thank you for sharing. We'll be right back.
Thank you.